Hello everyone, I was lucky to be part this year of the BAU annual congress to talk about the management of the patients with favorable outcomes after neoadjuvant chemotherapy for muscle-invasive bladder cancer, and do we need to do radical cystectomy in these patients. First take-home message, neoadjuvant chemotherapy, cisplatin-based regimen is the standard of care treatment for muscle-invasive bladder cancer with radical cystectomy and lymph node dissection. Second take-home message, we know that no residual disease on the final pathological specimen of the radical cystectomy after neoadjuvant chemotherapy is associated with favorable outcomes in terms of overall survival, and we know this from clinical trial data, the SWOG data in 2003, New England Journal of Medicine, and also from retrospective multicenter daily practice data. Third take-home message, what do we do with the patients that had no residual disease and do not want to undergo a local treatment? Several retrospective studies support the fact that in highly selected patients with no residual disease, we could propose a bladder-sparing strategy. Especially the patients with cT0 disease, a small tumor size under 2 centimeters, and also who have complete TURB prior to neoadjuvant chemotherapy administration. 2 ongoing clinical trials, one European, one American, are evaluating that matter, especially a French study named RECHIVE, evaluating active surveillance in patients who had complete response on a re-TURB after induction chemotherapy 6 cycles, cisplatin-based. The main endpoint is bladder-sparing survival at 5 years. The second study from Fox Chase also includes patients with no residual disease after neoadjuvant chemotherapy, cisplatin-based, 3 cycles, and complete TURB to either undergo active surveillance, local treatment in terms of radiation therapy, or radical cystectomy based on the presence of residual tumor, no residual tumor, or muscle-invasive residual tumor on the re-TUR specimen. Finally, immune checkpoint inhibitors are coming in the neoadjuvant setting with high response rates, high YPT0 rates, 29 to 40% in the Abacus and PURE-01 trial. This questions the added benefit of performing a localized treatment after these immune checkpoint inhibitors in the near future.